My name is Miguel Nobre. I am the Research and Development Director at Malo Clinic. And we are going to start this presentation with a context, which is the only way that makes sense for them to interpret the results to make sense for you. So in order to do that, we're going to divide this into a time frame. So we'll start with the past, then the present, and then the future. Okay? Okay? Hang in there. One last push. Come on. Then we go for lunch. All right. So the past. The past takes us back to 2003, when the first All-on-4 study was published in the mandible. The three authors, well, this one is particularly known, Professor Paul Malot, but also Bo Rangert, which was the chief scientist at Noble Biocare at the time and the one responsible for Noble Biocare to accept the All-on-4 concept, and a random kid that happened to be at the right place at the right time. So the results were 98.2% survival rate on the routine group with 1 year of follow-up. Why do I bring you this particular study and this particular result today? Because the questions that we are getting now for our study with All-on-4 and PEAK were basically the questions that we had back then in 2003. So 1 year, 98.2%, we were very happy. But then again, every time that we publish something in the mandible, the comments are, oh, but the maxilla. And the maxilla was 97.6% survival rate at 1 year. So with these two short-term follow-up studies, we established the landmark for the All-on-4. And this is the past. The present means another landmark. This year, we were able to publish two very important studies in our perspective about the All-on-4. The first one, the long-term follow-up in the mandible with up to 18 years of follow-up. Not just 1 year anymore. Did the implants fail? The majority didn't. So we were able to achieve high survival rates in a long-term follow-up for the mandible, at the same time as we maintained healthy marginal bone loss on the long term, both at 10 years and at 15 years of follow-up. What about, but the maxilla. So what about the maxilla? The maxilla, we also had the pleasure of publishing the long-term follow-up up to 13 years, and the characteristics were basically the same. The results were characterized by a high survival rate at 10 years, while maintaining also stable marginal bone levels on the long term. So this is the present. But how do we get to these results? So first, we have to make assumptions. You need high-quality material, of course. And you need high-quality clinicians and technicians that can produce. And fourth, but not less important, you need preferably high-quality patients. Preferably because you don't get to choose the kind of patients that you rehabilitate. And the longer you rehabilitate and the longer you excel at rehabilitating these patients, the harder the cases appear at our clinic to be rehabilitated. So there's another assumption that we need to make here before we go into the results. We are talking about All-on-4. All-on-4 is a rehabilitation concept based on the placement of 4 implants as cornerstones. 2 posterior implants tilted distally, 2 anterior implants placed in an axial position. We are not here talking about 4 on all. So this is All-on-4. This is a landscape, and may I suggest an ugly one. So basically, the All-on-4 concept happened not because we are freaks about the number 4 or because we wear shirts and our favorite number is the number 4. As you see, we are not fundamentalists. This is published, okay? So you can check it later if you want. The question is, when you have full bone volume, if you have enough space and confidence to place 6 implants, go ahead. The problem is not the number. The problem is the quality, the bone quality that you have in posterior regions. And what makes you feel more comfortable? Placing a good implant or placing 2 implants? We've been there. We published this study in 2003 with a development group where we placed 4 implants with the All-on-4 arrangement, and we placed 2 implants as rescue implants. Why? Because we were afraid. And this is also true for the maxilla, as already shown by my colleague, Dr. Carlos Morguedes. So it depends on the bone quality. Tell me, how many times, you surgeons in the house, is that so common that you find excellent bone quality on the posterior regions? How often does that happen to you on a daily basis? So that is why, if you have the possibility of placing 6 implants, go ahead. Or you can choose to perform the All-on-4. Then what we do is we adapt depending on the pneumatization of the maxillary sinus, and we move the implants closer to the midline as the resorption increases. And when we don't have the possibility to place a standard implant anymore, then we start placing zygomatic implants. And then there is no bone in between the canines to place a standard implant, then we place 2 zygomatic implants. And then if there's no possibility to do that, then bone graft. So no fundamentalisms. But what if there is no maxilla? Like in this patient that we had to rehabilitate, where due to cancer, we didn't have what we needed in terms of bone quantity or quality to rehabilitate the patient. However, we were able to do it through zygomatic implants and custom-made pieces for the prosthesis. And today, this is the CT scan where you can see there is a rehabilitation. We're at the EAO. Usually, most of the things discussed here go around dental implant insertion, surgery. And then a big portion goes around prosthodontics. Every time I hear or discuss about the All-on-4 concept in a congress like this is what I hear: surgery, prosthodontics, prosthodontics, surgery. And then I go thinking, what about maintenance? That's the difference for the monoclinic protocol. Is because for us, the All-on-4 concept is a 3-arm monster, where surgery, prosthodontics, and maintenance have the same importance. So when you connect the definitive prosthesis on your patient, at that point, everybody is happy. Surgeon, prosthodontist, dental hygienist, dental assistants, dental technicians, patient's family, everyone is thrilled. But then, there is a whole lifetime to go where the patients are exposed to risk factors that may jeopardize that success that you connected today. So usually, success is treated like a straight line from point A to point B, when it's clearly not the case, at least in maintenance. Because if you want to get the success, you have some curves that you have to go through. And you miss one curve, and this is what happens to your success. It's gone. So let's start addressing the threats to success by learning from the past. I place you here a graphic that is 20 years old, made by Professor Tonetti. In this axis, you see the hazard ratio. Let's address it as the ratio of something going wrong, the probability of something going wrong, and this X is the time. So Tonetti published this, referring that it appeared a higher hazard ratio of losing an implant immediately after implant insertion, and then that probability seems to go down with time. But at the same time, there is an increase in pockets and bone loss. Let's focus on the left-hand side of the graphic. So here we're talking about the failure of osseointegration. How do you address this threat? Well, if you had the chance to visit our clinic, you'll see that its size provoked that we needed to separate things into departments and give responsibility to departments. So it means that when the patient is intervened surgically, then on that day forward, he's delivered for the oral hygiene department, of course, always with the support of both the surgical and prosthodontic departments, to take care of the patient for the first 4 to 6 months. So our mission is to deliver back the patient to the definitive prosthetic phase for the manufacture and connection of the definitive prosthesis. For that, we need to take some short-term goals, which are prevent infection, decrease the patient's discomfort, and induce the healing of both hard and soft tissues. So to do that, we separate very clearly into what is the patient's responsibility and into what is the clinician's responsibility, because we give treatment a warranty. And so for the patient to use that warranty, he needs to comply with certain rules, one of them being present at the maintenance appointments. So that's the responsibility of the patient. The responsibility of the clinician is to do an excellent job at prophylaxis, but most importantly, on diagnosis. So this graphic from Glauser represents what happens immediately after implant insertion and over time regarding the passage from primary stability to secondary and final stability. So why is this strength measured in hertz highest for both Thionite surface or machine surface implants at the beginning? Because usually when you do immediate function, you know that you do under preparation. So when you place the implant forcing it. That is why you have that high strength. But then it happens. It goes down and stabilizes, reaching that plateau in between 3 and 6 months. So what do we do with this curve clinically? We design our maintenance protocol around it. So that is why the first appointment, it's pre-surgical, then 10 days, 2 months, 4 months, and 6 months. Why do we give 5 clinical appointments to the patients? Option A, we want to charge more euros so that everybody is happy in terms of economics, at least from our side at the clinic. Or option 2, you work around this curve because a little issue during this time is never little. I don't have time to go through the specifics of the appointment, so I prepared just a little 1-minute video to show you what we do in terms of diagnosis. It's just to wake up. Okay, so simulating an appointment, you can leave the sound higher. So first we're going to remove the prosthesis. Prosthesis out, and then we start collecting indexes. The first one, clinical mobility. The second one, suppuration by finger pressure. The third, modified plaque index, modified bleeding index, and probing. We call it the hand. Mobility, suppuration, plaque, bleeding, probing. And now that I don't want to get in trouble in terms of copyright, Okay, so why do we do 5 clinical indexes? Because if you do the 5 clinical indexes, you calibrate in between each index's sensitivities and specificities, and that will give you higher accuracy on diagnosis. So it means, practically, that the probability of some problem passing you by is smaller. And that is all we care about on the diagnosis. Let's go then for the second phase of maintenance, where there's the connection of the definitive prostheses. I think that we all agree that the major cause for late implant failure is peri-implant pathology, characterized usually by the presence of bone loss and the concurrent presence of probing pocket depths, increased probing pocket depths. First parenthesis, why don't we call it peri-implantitis? Well, because we don't like the term. Luckily, we are not the only ones. This brilliant editorial by Zarb, Koch, and Albertson, it's a 1-page editorial worth reading, where they state that they're also critical of the term peri-implantitis. Why? Because basically it means that we are trying to fit periodontitis into the dental implants. And dental implants and teeth are different. And what we do is we try to fill the vacuum by our incomplete understanding of the implant-host interface and fill it with what we reasonably understand about the interface between host tooth. So what they propose is a conceptual framework that accepts that bone loss requires a multifactorial model. We fully agree with this. And we have been fighting against this for some years. There you go. Published in the International Journal of Dental Hygiene in 2006. Okay? Pardon me the detail. So, you have the definition, but what is it? Is it just caused by plaque? We don't believe it. We believe that it's a group of multifactorial situations that have the intervention of both biological factors like plaque and biomechanical factors. Now that you have the definition, usually the clinical manifestations are pretty much settled in the literature with increased pockets, but really this is what is really necessary, a vertical bone loss or an attachment loss of more than 2 millimeters. But what's the prevalence? And this was the start of a great study that we published. So the prevalence, if you check this study by Zitzman in 2008, what do you do with a range between 28% and 56%, or even worse, between 12% and 43% of prevalence? Well, and you may think, with good reason, well, you're placing an old reference. This is 11 years old. So maybe today it's more accurate, that range. Is it? Ooh. Maybe it got worse. So it's no one's fault, but it's everyone's fault, because we work around different definitions of the disease, and this makes it difficult to find in systematic reviews an accurate prevalence. And it has also another issue, which is it's very difficult to identify the disease sometimes because of specific environmental causes, of the host susceptibility, and this is especially true if your disease is caused by multiple factors, if you have a long period of exposure, or if you have subclinical stages of the disease, all of these common to peri-implant pathology, where most of the times the patients go perfectly asymptomatic with the disease until the disease is in such a state of progression that they feel something. And every time I hear about disease, I remember my Master of Epidemiology classes in analyzing the epidemiologic triad, the old thing, between environment, agent, and host. But even these epidemiological conceptual frameworks have their evolution. And we have an evolution to present, particularly for peri-implant disease, which is the fourth dimension that is not present here. Can you tell which one is it? I'm going to play some music. The theme of the music is the fourth dimension that is missing. If any of you get it first, shout it, and I give you a candy after I finish the lecture. Let's go. Ready? No? No one wins. Time. So time is your fourth dimension that is usually not present on epidemiologic triads, but should be. So what is the solution for you to improve your diagnosis? Is to do an epidemiological surveillance. As current practice, you don't need a research department for that, where you focus on risks, sources of exposure and pathways, and of course health events. And what does it comprehend? It comprehends a process of systematically collecting, analyzing, interpreting, and disseminating your events. Okay, so this ended up in a 22,000 patient study where, among other things, when we studied them for 3 years, we determined that the prevalence at our practice for peri-implant pathology was 13.9% at patient level and around 8% at implant level. Every practice should know this. What is your prevalence? So the steps that we propose to address this is a strategy based on 3 points. First, measure the risk. Second, manage the risk. And third, communicate the risk. Miss one, miss all. First step, risk indicators. What are the risk indicators for peri-implant pathology? So the other problem with peri-implantitis is there is usually this attempt to place plaque as the only factor causing it. Here you see a study with more than 1,000 patients. Each pizza represents a number of cases of disease present. So if plaque was the only factor, then plaque would be all over here. Plaque is this color. And if plaque was a necessary cause for the disease, then plaque would be on all the pizzas. But what you see, where is plaque? Is it here? No, 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 yes, 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 and no. So for us, it's clear that plaque is not the only factor, is one of the factors. And so we proposed a conceptual model for the disease. So the odds ratio is important to know when you analyze the characteristics of the factors that can provoke peri-implant disease. In our multivariable model, what happened? We found out that the history of periodontitis, bacterial plaque, bone level, smoking, bleeding, type of material in the restoration, lack of prosthetic, this fancy name means either a lack of passive fit or loosening of prosthetic components, the proximity of other teeth or implants, and their interaction with plaque are all factors that can influence peri-implant pathology. So it's nice to know that if you find bleeding, that patient has a 2.9% more chance of having peri-implant pathology compared to a patient without bleeding. This is also very good to know, but you don't do anything in terms of prediction with it. You do it with the beta values. But the beta values have a problem. Do you know what a geek is? I can see a couple here in the classroom. Don't mock geeks, please, because this is a serious issue. So if we put on geek mode, allow me, then we are able to resolve this logarithmic equation, and that will give you a tool where you can get right 4 years before in the prediction of 86% correct cases of who is going to have the disease and who is not. So it's a good tool, but it's for geeks. But if we put geek mode off, then maybe there is a chance for this to have some practical value on the clinical setting. And so we did the math, the geeks did it, and we transformed this into a score point where you, by judging the presence or absence of the characteristics, score your points, get a final result, and you have a profile of risk. Now you can do something with it. If you go to the Foundation for Oral Rehabilitation, which is here, www.4.org, then you will find this tool for free. You register for free, and you just go through the questions in terms of presence or absence, and when you reach the final question, the system will automatically retrieve you with the following information: the number of risk points, the risk profile, the recall schedule that we recommend, and we can download it and give it to the patient. Because if you are used to seeing a patient every 6 months, 6 months, 6 months, 6 months, 6 months, and then all of a sudden you turn to the patient and you say, no, this time you have to be back in 4 months. What do you think the patient is thinking? Oh, he is really worried about my oral health. Or is it, oh, he's trying to rip me off an extra appointment per year? It's the second. So it's good to have a scientific validated tool, which, by the way, is the first risk score scientifically validated in the history of implant dentistry. So measure the risk, manage the risk, communicate the risk. And with this, we finalize the present. So let's talk about the future now. And the future really starts now. So what is the potential contribution from peak infrastructure? These are the crude results. So we have implant survival rate of 100% at 3 years, a marginal bone loss of 0.40 millimeters at 3 years, which means, by the way, that we lost between 1 year and 3 years 0.03 millimeters of bone. And if you divide it in between maxillary and mandible implants, you get 0.38 millimeters for the maxilla, 0.42 for the mandible. The incidence of peri-implant pathology was 1 implant. The incidence of mechanical complications was 22.5%, but here, please pay attention that we included not only fractures, but the majority of events which were loosening of prosthetic screws or loosening of abutments. And a low correlation between plaque and bleeding. Let's go through the results then and interpret them. So first, how does it compare, the 100 survival rate? Again, let's go back to the studies that we published this year on the long term. Where was the success rate at that period of time, at 3 years? Well, in the mandible was here, and the maxilla was here. So this means 99.1% for the mandible and 97.9% for the maxilla. So it compares favorably. What about the marginal bone loss? So here, we already talked about this, 0.38 for the mandible, for the maxilla, 0.42 millimeters for the mandible. But there is something that we need to bear in mind during the analysis of the marginal bone loss. The average standard error in the measurement is usually 0.35 millimeters. So first, the difference between these two measurements won't be statistically significant. I'm not talking about clinical significance, because the 95% confidence interval, as you see, overlaps completely. So no significant difference won't come from this result. The p will never be less than 0.05, okay? That's another way that you can judge statistics. But if the standard error is 0.35 millimeters, means that we have to bear in mind that differences might be a little bit difficult to be true. So to these particular implants, what does a 0.35 millimeter stands for? It stands for a little more than half an implant thread. And I'm going to keep this here on the next slides, okay? So every time we're discussing bone loss, remember about this. All right, but this I can compare. What was the bone loss on maxillary implants at 3 years when we published this study? 1.52 millimeters. This I can compare. And the difference, as you see, is more than the 0.35 millimeters of the average standard error. So one comparison, favorably. But now this interesting result that started happening very early as the 1-year follow-up that we published. Bimaxillar cases with an average marginal bone resorption below single arch cases. Is it the first time that we see that? No. But even though it's not that common. But again, the difference won't be statistically significant because of the 95% confidence interval, and remember about this standard error. Interesting enough, if we dissect this and change and separate the single arch between maxilla and mandible, then you'll get that the maxillary implants that started with 0.38 millimeters end up with 0.5 millimeters when they're just single arch, while the mandible maintains roughly the same. It increased like 0.06 millimeters, which means that the maxillary implants got that result at the expense of the bimaxillar rehabilitations. The difference won't be statistically significant. The differences are very small. And again, remember about the standard error. But when we analyzed the 3-year results, we found out that some implants lost bone, which is normal. Some implants were roughly with the same marginal bone level. And some implants seem to gain bone. Now, I was born skeptical. And so first that made me run through data, double check it, triple check it. And then, of course, you always have to remember about the standard error of 0.35 millimeters. How many implants were these? These were 37 implants, which is basically 20% of the sample. But if I exclude all the bone, let's call it not bone loss, below 0.35 millimeters, then I only have the ones that have above that. We only have 9 implants. Those 9 implants have one thing in common. They are all bimaxillar cases, where peak infrastructure was occluding with peak infrastructure. I bring you just a couple examples. Is it just me that sees that the marginal bone loss at baseline, the bone level, sorry, was kind of here and here? And then at 1 year, it's kind of here and here. And then at 3 years, it's kind of here and here. And I zoom it for you. Is it just me that sees this behavior from the third thread to the first, and from the second thread to the first? I'll give you another example from the contralateral side. Baseline, here and here. I always complain on symposiums that the x-rays are never left long enough for us to judge, so I leave these as long as you want. Do we agree that the baseline bone level is here on the mesial aspect? You see here this radiolucent area? So here and here. There we go. 1 year. Here and here. 3 years. Here and here. Let's zoom. Am I the only one to see this behavior from the third implant thread to the first? And here we were between half and first thread. We lost a little bit. We recover a little bit. What does this mean? It means that I am eager to see the behavior at the 5 years follow-up. Does it happen with all the implants? No. It happened with a smaller percentage, but it happened. And so all I'm saying is be skeptical, but give data a chance. Another important aspect is the correlation between plaque and bleeding. Why? Because usually when you find high plaque levels, you tend to find high bleeding levels. Giovanni Salvi did this study where he picked up some poor dentistry students and asked them to refrain from dental hygiene habits for 3 weeks. So what happened? Increased plaque levels, increased bleeding levels. Then at the end of week 3, he did prophylaxis, and he asked them to go back to their old habits. And so basically what happened was plaque index turned to 0 and bleeding index tend to come down. So here what you see is a positive correlation, and here what you see is an inverse correlation. This is what we expect. The results on our study at 6 months were this kind of correlation, which is a low correlation. So again, the closest we are to 1 positive correlation, the closest we are to -1 inverse correlation. But what happened at 1 year? It turned out to be a non-significant correlation. You see that plaque levels increased from 1 to 2, which means that they increased from only plaque visible after you perform the exam to number 2 units, which means plaque visible by the naked eye. But the bleeding levels stayed the same, with isolated bleeding spots visible. And finally, at the 3 years, we got again a low correlation. Bleeding levels stayed the same, plaque levels stayed the same, but bleeding levels did not accompany the plaque levels. And if you try to fit a quadratic curve in this data, this is what you get. What's the trend that you see here? None. So how did this influence peri-implant pathology? If we pick the risk score, then I can tell you there is a number of factors that the peak infrastructure won't influence and is not supposed to. But there are a couple factors that they can influence. The lack of passive fit and non-optimal screw joint they can influence, or they should influence, based on their CAD/CAM workflow. The bone level influenced because you see it was far from the medium third, and the material in the prosthesis, it's also something that influences. So in between risk points, we're talking about a lot of points of prevention here. That represented a result which adjusts to the scenario. 1 implant with peri-implant pathology, which represents 0.5% of rate. But how does that compare with the other results that we had? Again, the long-term studies. What was the prevalence of the disease at 3 years? Well, on the maxilla, 3%, on the mandible, 2.1%, both at implant level, which is what we are addressing here. So, again, it compares favorably. Is that question ringing on your mind? But you have a small sample. Yes, we do. It's a small sample of 196 implants. But that was exactly the same thing, question that people did to us when we published the All-on-4 in the mandible and in the maxilla. Give data a chance. So summing up, based on a high survival rate, low marginal bone resorption, an incidence of biologic complications with almost close to absent, an incidence of mechanical complications that is important, nevertheless, low percentage of major concerns, and a high patient satisfaction that we didn't refer to much, but when you ask the patients about their overall chewing feeling and their in-mouth comfort, their evaluation average was 90%. And if you check the literature in implant dentistry, when these parameters are evaluated, it also compares favorably. So based on these results, it seems there are good conditions for a good prognosis for the long term, which is basically what we want. And so the message still prevails. I have 3 take-home messages for you. First, when you connect your prosthesis and you're super happy with that excellent result, imagine your car in 20 years from now. So there's a whole lifetime to go. And the way that you get to the successful long term is not to think about that. It's to think step by step between today and the next appointment, today and the next appointment, and so forth until you get to the long-term result. And finally, my last slide, based on the results, this message that we passed in Madrid, in Vienna, and now in Lisboa still prevails. Regarding implant dentistry, based on the results, maybe PEEK could be the next periodontal ligament. Thank you very much for your attention.